welcome everybody. My name is Sonye Danoff. I appreciate the invitation that the organizers gave me to get to talk about a topic that I think is something that is often very hard for doctors to do. And what I hope that I'm going to do in the next couple of minutes is try to give you some tools to work on this with your doctors, because I think that these are some of the most important questions that every person who has pulmonary fibrosis really needs to wrestle with. And I think that it's not for wanting to discuss these issues, but I think that they're just very difficult. And so what I'd like to do is really kind of give you a framework for thinking about how we talk about prognosis and goals of care. So I don't have any conflict of interest, but I do think that one of the most important limitations that we all as individuals, and certainly I as a physician have, is that there are things that take us out of our comfort zone. And when we're outside our comfort zone, we're often not willing to talk about those things. And there are very few things that make people feel as uncomfortable as talking about the end of a life. So I want to say that this is something where I feel like none of us should be outside our comfort zone. This is something we all face, and the ability to actually face it in a productive way often makes our lives in much better control while we have them. So what I want to do is I want to consider how best to address these ideas of prognosis and goals of care, both for yourself if you're a patient and for your loved one if you're a family member. And I think that the essence of this is the concept of a conversation. I mean, a conversation is really an exchange of thoughts and opinions and feelings, and that's how we have this. This is not something which happens in a single moment, which is a single number or a single diagnostic test. This is a kind of evolution of understanding that people have, often within a family, but also between patients, families, and their caregivers. So when we talk about prognosis, what people often think about is this is the road that I'm going to be taking? What is the likely course of the disease or the illness that I have? And sometimes people think of it as how many years do I have? But what I really think of it is that prognosis is really the combination of the quantity of life and the quality of life. And sometimes we really are focused on quantity of life. If you all were there this morning at the first session, as physicians, we've been thinking a lot about, when we design drugs, are they going to increase the quantity of our patients' lives? And that's obviously amazingly important. But I think that another big part of this is the quality of life. What can you do with the time that you have? And that's true for all of us. So I think that the place we have to start, and you've heard this really from both of the previous speakers, is really what do we mean by the term pulmonary fibrosis? And I have to say that although I highly admire the Pulmonary Fibrosis Foundation, I don't love the term pulmonary fibrosis because I think it's confusing. And I really like the term interstitial lung disease, which you heard used a little bit earlier today by Joyce, because this is really a group of diseases. It's not one disease, and it's very easy to confuse the concept of pulmonary fibrosis, which is a group of diseases, with idiopathic pulmonary fibrosis, which is a single individual disease. So what we can firstly say is that these are very rare diseases. As a group, these are very rare diseases. And I probably overestimated. I think it's about 500,000 people in the United States. You'd have other people say it's about 200,000. So this is very, very rare in comparison to more common lung diseases like COPD or asthma, which may occur, 20 to 100 times more commonly in the population. At the moment, it looks like the incidence of pulmonary fibrosis is similar worldwide, although the demographics, the types of disease that people have differs, as you heard a little bit earlier. Idiopathic pulmonary fibrosis is only one form of pulmonary fibrosis, and there are many non-IPF forms of interstitial lung disease. And the reason why we spend what seems like an awful lot of time thinking about this is because these groups of diseases are actually treated very differently. and often are associated with very different prognoses. So one of the first questions that I hope that you will ask your doctors, or you'll ask the doctor of your loved one, is, does my loved one have idiopathic pulmonary fibrosis or some other disease? Because that distinction is extremely important. Now, one of the ways we can think about this, and you just heard this from Kevin, is there are a lot of different things that can trigger this injury in the lung, like autoimmune diseases like lupus or rheumatoid arthritis, medications that we use for other things that are, very important for other diseases, things in our environment. But all of those are completely different from idiopathic pulmonary fibrosis and need to be treated in a different way. One way you can see this is that when we look at sort of average age of diagnosis, people who are diagnosed with IPF tend to be diagnosed in their 60s. We rarely see people presenting before their 60s, whereas patients who perhaps have pulmonary fibrosis in the context of an autoimmune disease very frequently are diagnosed at a much younger age. The average age is 50, but I have patients in my clinic who are diagnosed as teens. So clearly, these are very, very different diseases. Now, I'm going to spend a lot of time thinking about this because it's so easy when you get a diagnosis of pulmonary fibrosis to look it up and say, oh my God, this is idiopathic pulmonary fibrosis, and I've looked at all of these things, and perhaps your doctor sees it in the same way. But what I would say is that really the point Kevin was making is that the most important first step to understand what your prognosis, what this road is that you're going to travel, is to be sure you actually understand what disease you have. The non-IPF interstitial lung diseases are probably equally likely. It's just they occur in different age groups and with different risk factors. They generally have better prognoses and they're more responsive to therapies. So there are many other types of medications or environmental modifications that are important for people who have non-IPF interstitial lung disease. And again, it's an incredibly heterogeneous clinic. I have patients in my clinic who have non-IPF interstitial lung disease who are 90 and who are 18. So it's a very, very broad spectrum. Okay, so let's talk about what we understand about this idea of prognosis. So how do we decide what prognosis is for an individual? Well, I've just said that the first thing is, what disease do you actually have? So if you have IPF, the ideas about your prognosis are going to be very different than if you have, say, connective tissue disease, interstitial lung disease, or if you have Birdfancier's lung. We look at things like the patterns on lung biopsy and chest CT scan, and you've heard really nicely from both Joyce and Kevin about how we actually look at those and how we try to separate what those pictures look like. In part, that's to try to help us understand what the disease is. Part of that is that when we say to somebody, here's the disease you have, here's the course we want to take, we want to have absolute certainty with that. So we do spend a lot of time thinking about diagnosis. And what I heard earlier today is many of you felt that one of the most frustrating pieces of your course was this lack of getting to what's wrong with me? What is this diagnosis? And we share that sense of frustration with you. We want to give you the right name for the disease because that way it gives us a place to start with what else to do. There are other things about how the disease is behaving that help us understand prognosis. Things like those pulmonary function testing that you heard about earlier. If those numbers are lower, it tells us that there's been more damage to the lung, and that tells us something about what the pathway will be forward. If you need oxygen, it tells us about that diffusing capacity, that ability to absorb oxygen from the air. The other thing is that the reality is that there are a lot of characteristics of individuals, like age. And one of our colleagues, actually some of our colleagues who are here, Brett Lay is the first author on this study that was done a couple years ago. They went through and they said, okay, let's look at all the different things that help us understand prognosis. Some portend a better prognosis, some a worse prognosis. And so he came up with all of this list of different markers. Some of these are related to the person, how old you are, whether you're male or female, what your racial or ethnic background is, whether you're smoking, if you're short of breath. So you can see there's a wide variety of these things. And based on understanding those kinds of features in groups of patients, they've come up with models. And again, the GAP model is a model which was developed with a number of the specialists who are here at this meeting. And these models basically say, for a group of people, if we take into account things like gender, age, pulmonary function tests, we can make a prediction of what is the likelihood that you will be alive in a year or 2 years or 3 years, okay? And again, this is a model which was initially developed for idiopathic pulmonary fibrosis, but has now been shown to be useful in other forms of interstitial lung disease. There's another model, predictive model, called CPI, which is based only on pulmonary function testing and is also used. But now what I want to tell you about is why models are very difficult for us to take. So you would think, okay, I can plug in my numbers and I can sit down in front of my doctor and say to my doctor, okay, doctor, how long do I have to live? And I'll tell you what the problem is. So I use this example of how we develop predictive models. So this is a model where you can see that on this side, we're looking at how many hours a student studies. And on this side, we're looking at how they do on their test. And so, you know, better on the test, better, more hours studied. And you can see that there's a line, which we call a best fit line. And when we get data about a whole bunch of patients, we develop a best fit line. So if you then look at this, you can see that this point is exactly on the best fit line. So this person, you would predict if they studied 3 hours, they'd get a 3 on their test. And that would be the perfect predictive model. It would fit exactly to the prediction. However, if you really look at the data, there's this person who did 3 hours of studying, but they got a 5. That person was incredibly lucky. And then you have this person who studied for 3 hours, but they only got a 1. So that person was very unlucky. So what I'm trying to point out is that even though we can develop best fit models, the model is for a group. It's not for an individual. There's a huge amount of variation for the individual. So if we change these axes and we say that this is now the axis of age, and this is the likelihood of dying, well, we know it's more likely we're going to die the older we get, but there's a huge amount of variability for every individual. So the problem is we can build models, but the model only applies to 100 people. It doesn't apply to one person. And that's part of the reason why it's very difficult when you sit down with a doctor and you say, well, what's my prognosis? Well, they can say, you know, I know it's not great, or I know it is great, but I can't give you any specific details. And the truth of the matter is, I think that's one of the reasons why doctors don't talk about this, is we hate not knowing the answer. It makes us feel terrible to have to stand up in front of you and say, I've done all this work and all this study. I have no idea. So what it turns out is that we're generally pretty good at understanding when people are very, very close to death. And so I always tell patients, I can probably predict if you're within 48 hours of death with a fairly high degree of certainty. But beyond that, it's wide open. I may know that you're not going to live 50 years or 40 years or 30 years, but I couldn't tell you in a scale whether it's going to be weeks, months, or years, because there's a huge amount of variation around that data. Okay, now this is one of the studies that was done that looked at just about, if you take 100 people and you say, how long are you going to live with a diagnosis of IPF if your age is less than 65, if your age is, you know, all these different categories. And what it shows you is something which makes a lot of sense on the face of it, which is that if you're 85 years old, the chances are you are not going to live as long as somebody who is less than 65. And part of what is sort of frustrating about this is that the obvious things really are obvious and they're true, but it doesn't really help us in communicating at an individual level, because I can tell you that around this median survival, there's probably somebody who survived 20 years and there's somebody who survived 1 month. So when you walk in and ask me, who am I in this table, I can only tell you in the most general terms what the likelihood of your survival for a period of time will be. And really, it all comes down to this. It's, you know, it's the 1,000-pound gorilla in the room. Everybody wants to have some element of certainty around death and dying. And, you know, it is really no different for any individual. I think it just becomes a little bit more Immediate, when you have a disease that you recognize as a disease which typically or often or sometimes leads to death. And that is within the spectrum of interstitial lung disease. So what I've just told you is that as an individual, I can't tell you when you are going to die. But what I can talk to you about is I can talk to you about what matters to you between here and that point. I can't tell you when it's going to happen, but we can talk a lot about the pathway to get there. And so when we talk about goals of care, what we're really saying to you is we know that there is the inevitability of death at the end of the day. You know, this is going to happen to each of us. It's going to happen to some of us sooner than others. How do you want to get to that point? And a lot of the things that we hear are, you know, I want to live as long as I can. I want to live as well as I can. I don't want to be dependent on people. I want to be comfortable. I want to be in control of myself when I come to the end of my life. And those are the kind of issues that I think are really important to address with your physician regarding goals of care. So how do you actually get to goals of care? And I have to say, this is, again, not something that the medical system is really intended for because it doesn't come on a prescription, okay? This is actually a very long conversation. And it starts out sometimes with your doctor. You know, doctor, how long do you think I'm going to live? And you know, what is it that I can expect to have ahead of me? Because I think that that's a legitimate question to ask. What do you think is going to happen to me between here and the end of my life? And then you want to have the conversation with yourself. What do I want? How do I want to be in control of my life up until the time I have my last breath? You have to talk to your family and your support system. They need to understand what your goals are for yourself. It is very easy to say, well, I'll let them decide. But that puts a tremendous burden on them that they would rather have you help guide them. And maybe you'll say, you know, I don't exactly know what's going to happen, but here's sort of the general ideas of what I want to have happen. And so really, at a time where you may not be able to advocate for yourself, it allows for the people around you, your doctors, your loved ones, to advocate for you. So when I have this conversation, both with my colleagues, doctors, and with my patients, here are the kind of things that I hear. And the first one is, I don't want to talk about this because I don't want my loved one to be worried. Well, I have to tell you, they've noticed this. It has crossed their mind. If it's crossed your mind, it's crossed their mind 20 times worse. Because when you're a loved one watching somebody suffer, it is a very, very frightening thing. And a lot of people say, you know, I'm not sure what I want. And I think that that's also a very legitimate concern. But unless you start to think about it, how are you ever going to decide what you want? Or how are you going to decide who's going to make those decisions for you? When doctors talk about this, I frequently hear this, I don't want my patient to feel that I have given up on them. And I would say that that is really the worst rationale I've ever heard. You know, if I can't cure you, I can't take care of you. My responsibility as an ILD physician is to take care of you in the best way I can, and then to make sure that when I can no longer cure you or make you better, that I make sure I get you to the end of your life in the most dignified way I possibly can. And a lot of people say it's too depressing to think about it. So what I would say is think about it this way. Benjamin Franklin said that in this world there's nothing that can be said to be certain except death and taxes. And what I would say is there just isn't a whole lot of chance you're going to have say in whether you're paying taxes. But this is an opportunity to have a say in the terms of your life and death. When you have the conversation about goals of care, it doesn't prevent you from dying, and it also doesn't make you more likely to die. But it puts you in control of deciding what really matters for you as an individual. I do want to talk a little bit about palliation, which is the idea that we do reach a point where we can't fix the problem, but it doesn't mean that we can't help to control the symptoms. And I really think that we should have a commitment for every physician to take every patient to the end of their life with comfort and dignity. And sometimes it takes you reminding us what we are forgetting to ask. I'm having trouble walking in. Okay, maybe my oxygen level is low. Maybe I need to be on supplemental oxygen. It's hard for me to go out to dinner because I can't park close enough because I don't have handicap tags. You would think we would think about this stuff, but often it gets lost in the day-to-day, which medications are you on and what do your pulmonary function tests look like. So remind your doctors about the things that will help you. we often forget to ask about shortness of breath and cough. There's also a very important piece of this, of emotional support, both for our patients and for our caregivers. And that's why we have these kind of organizations, because this can feel very, very lonely. But the reality is there are other people there who are going through very similar. Nobody will be going through exactly the same thing you are, but there are people who might be able to help you in giving you ideas or else helping you find resources. And lastly, we like people to make defined goals of care. It doesn't have to be if X, then Y. It's just generally, what is it that you want for yourself? We do have this process called hospice, which is a really wonderful opportunity for people as they reach the end of their lives. We have people think about hospice when we think they have less than 6 months to live. It's a system which is built into insurance that allows us to mobilize resources for supportive people either in homes or in institutional hospice, and it focuses on comfort and control of symptoms. The other pieces of it that are very helpful is it gives respite to our caregivers who are often very tapped out by the illnesses of their loved ones, and it really helps after somebody dies to deal with the issues of grief and loss. So with that, I want to stop. I want to thank you all for being here. And as I said, we are very fortunate to have incredible philanthropic support from a number of our families and that we've cared for. But I think that the greatest thanks goes to our patients who really keep us focused on what matters. So thank you very much. I appreciate your attention.